Ryan.
I'm Josh. Nice to meet you guys.
My partner Josh, yeah. So we kind of told them we were both former ICU nurses. We went with Edwards for a long time. We both use this technology on the unit. Definitely helpful in kind of see what's going on with your patient, what interventions would help. And kind of selfishly, I always want to think of like what would make my job easier. And this definitely makes it easier. So you're really being proactive with your interventions, not waiting for something bad to happen and then reacting to that. So this is really very basic. If you have questions, feel free to interrupt. We'll go through it kind of fast, but I always like to start off is like, what does hemodynamic monitoring mean to you guys? You said, arterial lines before, right? That is, all we're doing is looking at pressure inside the arteries, veins, and heart. And then another big aspect of it is that we want to see how much blood content is, how much oxygen content is in the blood, right? We want to make sure our patients are perfusing adequately. So who needs it and why, right? I don't think the acuity on the units is getting any less, right? I think we're getting like more and more sick patients. So, right, if we can get more data to see what's going on with their patient, I always think that's a good thing. So obviously, if you have someone who you need to give fluid management to, someone who's has low blood pressure, or we want to look at that cardiac function data, right? Those are really important things to look at. And this is the goal, right? Optimize oxygen delivery to the cells. If we don't get oxygen to the cells, right, we can only undergo anaerobic metabolism for so long, right? Cells end up producing lactic acid, then they die, then they go to, right, organ failure, so on and so forth. So, right, we want to use FlowTrack and ClearSight. I think we're just starting off with FlowTrack here. This is just a regular A-line. The only extra piece to it is this little pigtail here to get our other hemodynamic parameters. So we'll go over the setup.
Just to give you guys a little perspective, these monitors and FlowTrack has been in the hospital for 7 years. It was in the OR first, and then the CTICU, and then the CICU, the heart failure unit, and now making its way down to you guys. The literature has supported it for a long time, and it's just everybody kind of catches on at their own pace. And now there's extra monitors to go around, so you guys are inheriting 4 of them, I think, and you'll have them to use. So this isn't new, though. That's what I'm trying to say. It's been around and trusted and used on patients to help make outcomes better for a long time.
Yep. And here, just kind of what Josh was saying, there's a lot of EV1000s that are getting replaced. Some units are getting the new hemisphere monitors. They both will work with this FlowTrack sensor, giving you the same data. Skip over this, you guys know all that stuff. This is really kind of I say like the meat and potatoes of the information here. So are you guys familiar with SVO2 or SCVO2? Have you seen those before?
I've seen it, but I don't know what it is.
Okay, so this is just, you get this, your SVO2 is a mixed venous oxygen saturation that you get from a Swan-Ganz catheter, and an SCVO2 is a partially mixed venous oxygen saturation. So really, we have 100% oxygen-rich blood coming from the left side out through the body, and when it comes back to that right side, that's where our Swan-Ganz catheter is. That's what's measuring the content of oxygen. Pretty much have about 75%, right? So in a healthy person, they use up 25%. You should have about 75% return. So this gives us a really good indication of how well our body is handling the oxygen demand and the consumption. So broken down even more, right, we have cardiac output, hemoglobin, arterial oxygenation, and tissue metabolic demand. The point of this is that your patients won't always have a Swan-Ganz catheter, right? Not every patient, that's mostly for cardiac. We now have technology to accomplish the same goal as making sure our patients are being adequately perfused. So if I can go into my room and check off these 4 things, I can be really confident that yes, my patient is perfusing, right? We're making steps to get them out of the unit a little bit faster. So on the oxygen consumption side, I always like to start over here because as nurses, we can fix these things pretty readily, right? If my patient has fever, anxiety, pain, shivering, muscle activity, they're bearing down with pain, like they're using up a lot of oxygen, right? We want to minimize that. Sometimes we just give them PRN pain medication. Sometimes we need to give them more sedation, or if they have anxiety, right, we can get a PRN for an anxiolytic. Does that make sense? So once we've kind of accomplished this side, we can focus our efforts on the oxygen delivery side. So you'll be working with respiratory therapists, right, getting ABGs and kind of seeing, what that information tells us. Sometimes we do need to change, right, ventilator settings, change the FiO2 when we get that arterial oxygenation reading back. right? You're gonna be looking at your H&H. If our patient's anemic or they're bleeding, there's just not enough trucks to transport that oxygen around and deliver it to the cells. So if we do draw an H&H and it's low, that's a pretty easy fix. We can transfuse. And then over here we have our cardiac output. Cardiac output, all it is heart rate times stroke volume. So there's a lot of information I know, but really the main thing is here, everything is conceptually related. So if one thing changes, it's gonna necessitate a change in the next parameter. So for example, say I'm working out really hard, right? I'm gonna have an increased heart rate, right? And an increased cardiac output to get that oxygen to my cells. So my oxygen delivery would be up, and if we were tracking my SVO2, that number would change big time, right? Same thing as you have like a hypovolemic patient, you're giving them fluid, well, right, their stroke volume is low, we're gonna give them fluid, that'll increase their cardiac output, which would change their oxygen delivery, which again, if we were tracking the SVO2, that would change, but does that make sense? That was fast. Do you want to add anything, Josh?
Yeah, I mean, really the goal of hemodynamic monitoring is to adequately perfuse our patients, right? If we were measuring an SVO2 on everybody and we were using hemodynamic monitoring, we had that number to go off of, that number dropped below 60, we know it's time to intervene. But with FlowTrack, you do not need to have an invasive technology to give you that number, because FlowTrack is going to give you what you need to optimize cardiac output, hemoglobin, arterial oxygenation, and tissue demand. And really, as ICU nurses, we do the H, the A, and the T without thinking about it. The piece that always gets missed, particularly in septic patients and cardiogenic shock patients and hypovolemic patients, is the C piece, and that is heart rate times stroke volume. Heart rate, how fast the heart beats, stroke volume, how much blood is coming out of the left ventricle every beat of the heart. If you take nothing else away from this hemodynamics class we're doing, is that stroke volume is a really important number. And we're gonna talk more about it, but you can really, really do right by your patients by optimizing their stroke volume and their preload.
Yes. Perfect segue. So we're gonna break down cardiac output a little bit further. Right, we said it's heart rate times stroke volume. So we do need an optimal heart rate. So for example, say you have a patient, maybe an elderly patient, they come in with sinus rhythm, right? If they get maybe they're going towards that septic pathway and they go into atrial fibrillation, right? Atrial fibrillation, we just lost that atrial kick that makes up 30% of our cardiac output. So we'd want to get them back into a sinus rhythm, but it's just a big deal in the equation of the cardiac output. And then as Josh just said, your stroke volume, that's just the amount of blood ejected from the heart every beat. Normal range is 60 to 100, same as your heart rate, easy to remember. Stroke volume is then broken down into preload, afterload, and contractility. Are you guys familiar with those terms?
No, but so confusing.
Okay, so we're gonna go into each one of those and make it really, really easy to understand. So really, right now we're really reacting. So say your patient becomes hypotensive. Why are they becoming hypotensive? It really boils down, right? They're either hypovolemic, they have some type of pump problem, or they're vasodilated. That's exactly what this is telling us. So preload is a good indication of the patient's fluid, right? Afterload, are they vasodilated or vasoconstricted? And then contractility, how well is my heart pumping? So we'll go into each one of those. If you ever see cardiac output, or you have a cardiac index, or you can have stroke volume index, that just takes into account the patient's body surface area. So it's cardiac output divided by BSA, that will get you cardiac index. It's just a little bit more patient specific. And the example I like to give is like me versus Shaquille O'Neal, right? We're gonna have much different, right, indexes. So going on, talk about heart rate. So preload, kind of said that, the amount of fluid in the system, right? It's really that volume at end diastole. So when that ventricle opens up and relaxes and fills, that's your preload, and then it snaps back. So right, opens up, stretches, right, that myocardium snaps back. That's your preload. Right now, what are you guys looking to see if your patients are volume resuscitated or optimized?
Like, what do you mean?
Like, you look at, how do you know if they need volume? Or if you give a fluid bolus, how do you know if that's actually the right amount?
You can do CP, you can do
Okay.
hemodynamics, you can look at their labs, you look at their eyes and nose.
Good. All right.
Blood pressure.
Yeah.
Yeah.
Somewhere where it's like you're above or below.
What's that?
Hypotensive.
There's just like this graph on the summary page that we have,
Mhm.
and it says like the fluids below and over.
Okay.
And it says like urine, and that one's yellow. There's a graph up there.
So it's like
Okay.
tracking ins and outs kind of thing?
Yeah,
Okay.
Mm-hmm.
Yeah, great. So, right, you guys spend a lot of time every hour. You're checking eyes and nose. If the patient does have some type of central line, you probably check a CVP. Okay, good.
Those are
So-
all great, but they're great assessment tools, not necessarily great indicators of fluid.
Right. Yeah, and we'll definitely get into that. So CVP, right, tells us a lot about the right side of the heart and how well that atrium is working, how that RV is working. But regarding fluid responsiveness, it's been proven to be about 50% accurate. So if I give my patient fluid, it's really a coin toss. Will that fluid actually benefit them or not? And then, we want to use more specific and sensitive parameters because CVP, right, it's a pressure. So if I have pulmonary hypertension or RV dysfunction, my CVP is always going to be elevated. I keep giving that person fluid, I'll never see a change in that CVP. But if we look at dynamic parameters like stroke volume and flow tracks updating every 20 seconds, so it's giving us a real-time look and say, if I give fluid, I should see an increase in my stroke volume pretty much immediately. If I don't see that, okay, though that just told us that's not the right intervention. I can use another, maybe they just need pressors, right? So this is the beauty of the machine. It's going to tell you, did I choose the right intervention and how much do I have to deliver that dose by? That's what makes your life so much easier because grabbing a bag of pressor or waiting for the pharmacy to deliver that, prime it, get it go, that's a lot of time out of our day. And now you're doing that for 1 or 2 patients or maybe even more patients, plus a fluid. So time is very valuable. So stroke volume, we said normal range 60 to 100, right? If it's less than that, right, pretty much assuming our patient would need fluid. If it's more than that, maybe we do need to diurese him a little bit. We don't want to talk about SVV or, okay. Okay, so to manipulate our preload, we always want to assess that first because the saying is I want to fill my tank before I step on the gas. If my tank's not full, I could add all the pressors, all the inotropes in the world, right? I'm just making that heart work really hard. So we want to make sure our patient's volume optimized, then we can go and assess those other parameters. So say, if I did have a stroke volume of 40, my patient has stroke volume 40, how can I increase that? What intervention would you want the doctor to order? Yeah, fluids. And what do you guys use here for your boluses?
Saline,
Yeah,
LR.
so saline, LR, sometimes even plasma, sometimes blood products that will help. Yeah, albumin.
Yes.
Yep, any of that to increase. And sometimes, maybe you have a patient who has CHF and you hook them up and their stroke volume is really high and maybe we do need to get some of that fluid off. So, right, you guys would give your Lasix or your Bumix, right? Good. Questions on stroke volume, preload? Make sense? Okay.
Brian just brought up a really good point, and this can be used both ways, right? Giving fluid and taking fluid off. So think about how many CRT patients do you guys have here? Do they have A-lines a lot of the time? How about a way to more accurately pull fluid off and look at what their stroke volume is doing rather than just guessing and then maybe pulling too much and they get super hypotensive and you put them on pressors and you're giving fluid back. It's just, we're critical care nurses, there's ways to critically think through this and make sure we're doing the right thing for our
Work
patients.
smart, not hard,
Yeah.
right?
Yeah, because a lot of times some of those patients, we can't even get them off a CRT, and then we have to sign them up for hemodialysis, and that's even like, we can go down that rabbit hole too. So we talked about our preload, say, preload's good, now we can check our contractility. Maybe our patient still needs, some increase in perfusion. Right, and that's just the ability of the cardiac muscle fiber, right, to contract. So we talked about our stroke volume, cardiac output or cardiac index, that's just the amount of blood ejected from the heart in a minute. Cardiac output normal range is 4 to 8, and your cardiac index is 2.5 to 4. Some of the new nurses, you guys remember the Frank Sterling curve from nursing school? It's not going away. No, it's actually very helpful. It's pretty much saying if I give some type of fluid, I should see an increase in my stroke volume cardiac output. That's basically what it is, right? You have that stretching, right? But we know that every patient is unique. So, right, if I was to give you 2 liters, you 2 liters, and you 2 liters, you'd all handle that extremely differently, right? It's the same thing with our patients. So we might have someone with decreased cardiac function. Maybe we have that 80-year-old CHF woman, right? We have to be really careful about how much fluid we give her. Compared to maybe we have a 20-year-old trauma patient, right? Their heart, we can load them up. They can really handle that fluid. They might need more than that. So That's exactly what the machine is telling us. It's an individualized approach to say, how much does this patient actually need? So if my cardiac output was, say our patient's was 2, it's pretty low, right? What interventions would you advocate your doctor to order? I don't know how much you use positive inotropes here, if any.
Use epi
Yeah.
Epi?
a bit.
Okay.
You guys
Yeah.
use dobutamine or dopamine?
Not a whole
Yeah.
lot, but we do.
Okay. Yeah, so, right, we have that low cardiac output. We want to have some type of inotropic capability to increase the contractions, right? So, yeah, dobutamine, milrinone, epi, that will all increase your cardiac output. And then sometimes, I'm sure you've seen, right, sometimes we have to let that ventricle really slow down, relax, fill, and then snap back. So if you want to decrease the cardiac output, you give your patient beta blockers or calcium channel blockers, right? Slow down the heart, and we actually want that ventricle to fill and then be able to snap back. Because if the heart's just like pumping, we're not getting very good, right, volume out. Cool? So we did preload, we talked about contractility. The last one would be our afterload. And I kind of refer to that as the size of the pipes. What is my heart pumping against? Like I said, is it something the size of a garden hose or something the size of a straw? So it's just the resistance in which the ventricles have to overcome in order to eject that blood out. So for example, maybe we do have a septic patient, right, with like really low blood pressure. If we hook them up and their SVR was 500, right, they're really vasodilated. Or maybe we have that older patient who has, hypertension, they're a smoker, they have arteriosclerotic disease. We probably anticipate them having a much higher SVR, right?
So SVR is systemic vascular resistance. We don't typically utilize these.
Gotcha, okay, yep. Yeah, so SVR right down here is your systemic vascular resistance in normal range, 800 to 1200, 800 to 1300. It's kind of the normal range there. So if it's lower than this, my patient would be vasodilated, and if I add a pressor, that would increase it. And sometimes, right, we have a patient, maybe they come in with like hypertensive crisis, super high blood pressure, or maybe, you guys take care of post-op patients, maybe they're just in a lot of pain. We want to make sure they are fluid optimized, because I've seen before where the patient is hypovolemic and we give them pain medication, and it's like, boom, it wipes out their sympathetic drive, right? And they're just, now you have like a really, really low blood pressure. So again, if we had that patient, right, preload's okay, our contractility is pretty good, say our SVR was 400, and we want to increase that blood pressure, what would you guys want to see the doctor's order?
400 is low.
Well, yeah,
Yeah.
use pressors.
Exactly.
Yeah,
Clamp them down.
Yeah, so I'm sure your first go-to here is Levofed, right? Right, we have vasopressin, we have Neo. So those are.
You guys use a lot of Neo too? Okay.
Yeah.
Something to keep in mind with Neo versus Levo, right? Levo is going to be beta 1 and beta 2 with a little bit of alpha, so it's going to clamp you down, but it's also going to help increase the squeeze of your heart just a little bit. And a lot of people forget about that. So if you have a patient who's having a little bit of contractility issue and low blood pressure, you might see your cardiac output bump up a little bit if they're on Levo. Whereas Neo does nothing but constrict, and it's all peripheral constriction. So take the heart and lungs out of the picture. All it does is constrict peripherally all around the heart and lungs. So picture you have a patient who has a high SVR, right? They're already clamped down. We haven't even talked about giving fluid or anything. We're just chasing blood pressures. Our MAP is 65. We keep going up and up on our Neo, right? Your SVR is gonna end up being like 28, 2900, and all we're doing is constricting peripherally. So think about what's happening to the kidneys and the gut when we just increase that SVR to mask our blood pressure, but there's no blood going to our vital organs, right? So that's when we start to get kidney injuries, and your BUN and creatinine bump up, and then they go on CRT and you're pulling fluid off even though they're not really tanked up. And that's when we start to really get in the weeds and have bad things happen to patients. So SVR to me is like the magic number. It's gonna tell you if you're clamped down, if you're dilated out. And combining that with stroke volume, you can think, hey, let's optimize our preload first and give some volume. And once we've done that, then we can optimize our afterload, see if our patient needs pressure or not. And if we've done both of those and the cardiac output drops, well, we know there's only one thing left that it could be, and it's contractility, so let's fix our squeeze. And that's the simplest way to think of it to me. It's SVR, it's stroke volume, and then it's cardiac output. And if you just use those three things, you can really do a better job for your patient.
Yeah.
Sorry.
No, I think that's like perfect. Much much helpful information getting the SVR and looking at the stroke line, because same instance, say you know, I'm keeping track of both those on my patient, and I go up on my levo, maybe by, you know, say I go up 4 mics, and I start to see my stroke line go down. Well, that means I went up way too fast on my levo, right? Because I'm really making that work harder, right? I'm clamping down. Maybe I need to lay off the levo, and you'll start to see that stroke line magically start coming up. So that's kind of a good go-to. If I go too fast on my pressors and my stroke line goes down, that means I went up way too fast. I can let it, like, you know, chill out a little bit. If that makes sense. So good. And like, you know, we kind of talked about if your patient has hypertensive crisis, or, you know, really high blood pressure, right? You guys use I don't know what your go-to defense for those are here.
You guys have nicardipine?
Nicardipine.
Use those?
That's a good one.
Yeah. So yeah, your nitro, your you know, hydralazine, all your ACEs and ARBs. We want to like really let that heart vasculature get a little more dilated. Good. So preload, afterload contract. Make a little bit more sense now? Okay. So you're still going to use your traditional vital signs in conjunction with your hemodynamic parameters, right? Because we're tracking those, we're tracking them every hour. We talked about heart rate, why that's important. We talked about CVP. So wedging with swans, we'll leave that for another day. In urine output, we kind of talked a little bit about that, where you're going to be monitoring your eyes and nose every hour. So you know, your patients, you know, their kidneys are really smart, right? They can actually lose up to 80 to 90% of their function before you see that patient become oliguric. So, right, keeping track, maybe they're like 30 every hour, and then boom, nothing. So again, we're reacting to something that has already happened, where if we did have, right, our continuous stroke volume up, we could start seeing that stroke volume slowly drift down here. And again, we're always looking at trends. We might not know something's going on, but we can look at the trends and be like, wait a minute, something's going on. Let's go talk. Let's bring this information, right, to our intensivist, and then we can kind of discuss the next course of action. And this is just why blood pressure doesn't tell the whole story. These are 3 examples of where your patient's going to have a normal blood pressure, right? The body's smart, but it's going to compensate in order to keep that blood pressure elevated. So an example, you have a cardiogenic shock, or maybe they're bleeding, right? The body's going to tighten up, and that cardiac output's going to go down. But it can only do this for so long. That's when you see the crash. That's when you call the code. So if we're keeping track of this continuously, we can kind of stay ahead of that. Same as in sepsis, right? Your patient's going to be really vasodilated, and then their heart has no resistance. So right, it really wants to get that oxygen out to the muscles. You have a high cardiac output, but again, can only do that for so long. And then this is just our happy patient. But again, all 3 examples with normal blood pressure. Again, I like, I don't know if you guys are familiar with the Journal of American Medicine. A lot of good information there. This is from '91, and I really like this quote because it says, it should be recognized that systemic hyperperfusion usually precedes hypotension, especially in patients with sepsis. I think that's really appropriate for the MICU especially. That hypotension that's not shock, right? That's a symptom. Shock is we're not getting enough oxygen to the cells. And you know, we can go down compensated versus decompensated shock. We'll talk a little bit, we want to talk a little bit about that on the next slide.
Yeah, sure.
But the main thing here is what we kind of talked about. If my patient becomes hypotensive and they're on vaso or levo, I can increase that levo to give them a map of whatever I want, 85, 100. But at that point, are we really perfusing those distal extremities or your kidneys? Because I've seen it, right? They have like necrotic fingers, the nose, the ears. That means, right, we went way too fast on the pressors. We're not getting good distal perfusion. So you need pressure and flow for good perfusion. If you don't have one, right, we're not going to get that good oxygen to the cells. Question on that?
Yeah, you guys have any questions so far? And we're throwing a lot of info at you, and we're trying to keep it really simple. Advanced hemodynamics is complicated. We can keep it simple.
Please.
Yeah, trying to keep this as simple as possible. What questions do you guys have? You can throw them at us.
They are good. Not good.
Yeah, we only have just a few more slides. We'll get over to the setup. I'm going to introduce this slide, and then Josh can kind of take it over. So this was actually a study done in the UK. One of the anesthesiologists actually works for a company now, and what they did was in a controlled study, they bled themselves out and they tracked their hemodynamics, and they wanted to see what's happening. So this is, right, the start, as we can say the patient is bleeding, right? And what's gonna happen with your hemodynamics, right? We kind of talked about that earlier. You're bleeding, right? Your body's going to increase its SVR, right? Increases vascular tone, as your cardiac output's slowly drifting off, but my map is staying the same. And then you get to this point where, right, that 18 to 20%, that's when your body can no longer compensate and you have that crash. You want to?
I feel like this slide speaks volumes, right? When I was a nurse, before I used FlowTrack, I had no clue. If I had a patient that was bleeding, we'd wait to see till the blood pressure dropped. And maybe they're bleeding slowly, blood pressure starts to drop, we'll intervene. 20% of that blood volume was gone by then. And if you're monitoring your patient closely and looking at your advanced hemodynamics, you can really work proactively rather than reactively. And that's really the most important thing. I have to run out and jump on a phone call in a second here, but I want to leave you guys with this before I come back in. There's places where FlowTrack and hemodynamics is completely nurse driven, where there's standing orders for the nurses who are hemodynamic experts to use this data and do what's right for their patients without even having to go get orders. There's orders for pressor, for inotrope, for fluid, and if the hemodynamics say, this is what the picture is, you guys can jump in and intervene, then go get the provider. It makes a huge difference. Hospitals save money. It's better for patients. So I would, empower you guys to get really good at this. It makes a difference, and that's why I love doing this job, because we get to go around and teach this class and try and improve outcomes at places. And it's different on every unit, right? Like, I can run through the shock thing real quick. I would imagine that you guys see three types of shock, right? Sepsis, hypovolemic, cardiogenic, are the three main ones. I don't know as much about neurogenic shock. They're probably over in the neuro ICU, and that's not my forte. But if you think about what you're going to see on your hemodynamics, right? Shock is going to present pretty similar in most patients. Your heart rate's going to be up, your blood pressure is going to be down, but they're all different. Think about a septic patient. What do you think your hemodynamics are going to look like? Let's start with SVR. So septic patients, do you think your SVR is going to be high or low?
Low?
Yeah, low, right? They're dilated out. So a low SVR means we're really dilated. So think low SVR, big dilated vessels. If our SVR is low, what's our cardiac output going to be?
No.
High.
Why?
Yeah, no wrong answers. Say what you think is right. If our SVR is low, right, meaning our vessels are dilated out, that means our left ventricle has no resistance to pump against. So it's just going to throw out all the volume that it has in there. I've seen a septic patient with an SVR of 200 and a cardiac output of 14. That's like absurdly hyperdynamic. So in early sepsis, we're going to see that crazy hyperdynamic. We're going to see a really low SVR, patient's really dilated out, with a really high cardiac output. What do you think your stroke volume is going to do?
Hold a minute.
It's going to be high, which is crazy to think about, because that patient is going to need a lot of fluid, and you would think that they would have a low stroke volume, but in this case, they're going to have a high stroke volume, because high heart rate, higher stroke volume means really, really high cardiac output, right? What do these septic patients need to fix this situation? Volume, and we got to fix the SVR too, right? So sepsis is going to be a combination of fluid, sorry for my chicken scratch, plus pressure. Because you need to fill the tank, and then you need to squeeze, right? We need to fill the tank to fix the stroke volume, the cardiac output, and then we need to clamp them down. That makes sense? That's probably the most common one you're going to see. But then there's the question of, how do you know that you're giving them enough fluid, or are you giving them too much fluid? And that's when you really want to use that stroke volume to guide your fluid, because if you give them 500 cc's in a bolus, you would expect your stroke volume to go up, right? The magic number for stroke volume is 10%. We didn't say that earlier, but if your stroke volume goes up by 10%, they're a fluid responder. They have responded to that volume. Let's think about cardiogenic shock. Pump's broken, right? The pump's not working. So what do you think you're going to see with your stroke volume and your cardiac output? Low, really low. And we were talking about SVR as our compensatory mechanism, right? So what's your SVR going to do? It's going to be really high, because it's going to try and conserve all of that volume for our vital organs. So you're just going to clamp down and clamp down and clamp down, try and keep the high pressure. But like we said, pressure does not always equal good flow. So cardiogenic shock, right? We're going to see lowish blood pressure, but that SVR is going to be clamping down as much as it can to try and maintain a map and autoregulation. What do cardiogenic shock patients need to get better? What do you expect to see? You got to fix the pump. Inotrope, right, exactly, inotrope. Or send them to the cath lab. Inotrope or make it somebody else's problem and send them up to the cardiac ICU. And then hypovolemic, you guys are gonna see hypovolemic shock patients a lot, right? High heart rate, low blood pressure, what do you think their hemodynamics are gonna show? What's the stroke volume and cardiac output gonna be?
No.
It's gonna be low, right? Because there's no volume, it's all right, that's what we're doing this for. This is a safe spot to learn. It's gonna be low, and the reason it's gonna be low is because there's no volume in the heart to send out, right? So what's our compensatory mechanism gonna do?
Hi.
It's gonna be high. These two look exactly the same, don't they? That's kind of alarming, that a patient who has a pump problem, that if you give them fluid, could kill them, versus a hypovolemic patient that presents exactly the same as far as numbers and stuff go. They're the ones that need the fluid. So that just makes having advanced parameters all that more important. If you treat a patient for the wrong kind of shock, they could die. My first patient at Wake Med that I had, that we put a flow track on, had a STEMI, came in, had it fixed in the cath lab, right? Came up to the unit and did not look good. So what did? We put them on inotropes because we thought it was a cardiac problem. They had a pre-existing condition that would have made it a cardiac problem, right? The Edwards rep came by, hooked the flow track up. It was right when we got the monitors for the first time. What do you think the hemodynamics showed? If it was cardiogenic shock, we would expect to see a really high SVR and low cardiac output. That was not the case. They had a really high cardiac output and a really low SVR. So even though they had a pre-existing, condition of a heart attack that they came in for, they were in septic shock. So who knows what was going on, what kind of infection they had, but we had that patient maxed out on epi, and that was not doing the right thing for them. So we weaned off the epi, we ended up giving like 7.5 liters of fluid, put them on levo, patient went home in 2 days.
Wow.
Whereas if they kept getting all that epi and all of that positive inotropy, they probably would have died. We would have killed their heart. It makes a difference. I'm really passionate about that. It really does make a difference.
Sure.
And please excuse me for a minute. I'll be right back.
So good information, kind of seeing the different shock types. Does that make sense, right? Because I think a lot of times, right, in my experience, I've had a patient with a retroperitoneal bleed. I had no idea the patient was bleeding, but I could see on my flow track machine that again, right, my SVR was slowly creeping up and my cardiac output was slowly creeping down. And again, I'm like, what is going on? Well, we did draw some labs. We showed, the bleed, low H&H, and then we were able to have the right interventions. But does that kind of make sense? Okay. What else? How are we doing on time?
We're a bit over. If we want to get to the machine,
Machine?
we can,
Sure.
we can share the information with them.
Okay. So has anyone set up the flow track here? Okay. So now you have, I'll just go over a few components. You have the EV1000 monitor. And on this monitor, we have a data box, a pump unit, and your regular screen. The pump unit is for a non-invasive technology, so you don't have to worry about that. The only thing you have to worry about is the screen and this data box where you're going to be hooking up your flow track. So over here in the back of this data box is this cable right here, and you can see there's 3 pigtails. These 2 are to to transduce a CVP. You don't need to do that. You can just hook up your CVP how you normally do. This is really the only one you need to be concerned about is a green cable, and you can just leave these just how they are. You don't have to put them together like that because it'll actually cause an error. But just the only one you need is the green. And in our flow track sensor, it'll come in a box just like this. Open it up. Again, it's everything's sterile in here. And like I said, treat it just like you would a normal arterial line. Make sure all your joints and connections are tight because sometimes during that sterilization process, they can get a little bit loose. And as you can see, you have your 2 pigtails here. So if I was just to hide this, right, this is pretty much just like, this is right, just like your A line here. The only thing is it's a little bit bigger and we've added a pigtail here. So I like to say red to bed, green to machine. So red to bed will just be your normal pressure cable to your bedside monitor. That'll just give you arterial blood pressure. Once you hook up the green to our machine, that's what's gonna get all your hemodynamic parameters.
are going through our A lines.
Yep, so
Okay.
this is your A line.
I
So
got
this is like your typical setup here.
I got you.
So really, we're only replacing this transducer here with this, I call it a smart A line. That's really it. So, right, you get your bag, spike it how you normally would. You have your pull tab here, prime it through, inflate it to 300 millimeters of mercury, flush it again under pressure, get all the extra bubbles out. We're all set. We can put that right here. The monitor is off right now. You plug it in, and it should turn right on, but there is an on-off button in the back here. So if you want, just power that on, and it'll take a few minutes to power up. So if your patient does already have an existing arterial line, again, maintaining aseptic technique, you could disconnect this, hook it up to your pressure bag, prime it through, and then put this into, right here, replacing this little transducer, if that makes sense. And I'll do that again once this is powered up. So you have a nice sound there. This monitors, it was only really intended for one type of technology. We just kept adding on. So now we have the new hemispheres that kind of incorporate all this, but FlowTrack on here just works really nice. Questions on the setup so far? Priming or anything? Pretty easy? Okay. So right when it comes on, it's gonna ask you for important data for your patient. So it's gonna ask for height, weight, age, and gender. So it's all touchscreen. Just make sure you're choosing the right increment up here, or the right measurement. Centimeters or inches, so we can put in 180 centimeters. Weight, again, make sure you're putting kilos or pounds, but 80 kilos. Our age, and our patient's gender. Once you've input those 4 things, all you do is hit the home button, and it pre-populates a 0 screen. So on here, if you ever see, this is actually kind of good, if you ever see it says clear site down here, it's gonna leave off on the last technology that was used. So just press that clear site bar, and now you can toggle between the technologies. So we want FlowTrack, and we'll hit, we gotta connect this, Josh, unplugged it. So down here, if anything is disconnected, it'll be blinking down here. So I don't know if you can see that. So see how there's this like little 3 boxes here? That just means one of these Ethernet cables is disconnected. For some reason, it's not letting us do this in demo. So I'll just kind of run through this with you. If you want to enter a new patient, I know we're kind of jumping around just a little bit, but to set this up again, if I go to this settings icon over here, it's kind of like the settings tab on your iPhone. You hit this, you have patient data right here. If you select patient data, you can go back in here and change, like say, I don't know, they were 90 kilos instead of 80, you can go back in here and change. But if I want to select new patient, I don't want to override this. I always want to hit the new patient tab. So I can hit new patient, yes, again. So now I can enter in patient's height, weight, age, and gender. Hit the home button. Again, to pre-populate this, I want to switch it to FlowTrack. So see how this button just lit up? It wasn't lighting up before because I did have some cables that were disconnected. It now will allow me to change it. Like I said, this is your 0 and waveform screen for the FlowTrack. If this disappears by any means, you have the nursing bag right here. Just go to your nursing bag, and you have 0 and waveform right there. Brings you right back here. So we have our, let's just pretend this is all primed and ready. Right, we have a radial catheter that our physician just inserted. So we'd have our red to bed pressure cable, and then our green to machine. There's a smooth side and a rough side, smooth to smooth, rough to rough, just like that. And then you'd go through your zeroing process. So at phlebostatic access, right, heart level, off to the patient, open to air, you'd hit 0 here. Go ahead and zero your bedside monitor at the same time. Come back here, close your stopcock, put your cap back on. You'll start to get your waveform, and then in 20 seconds, you'll get your continuous parameters. That's it. That's the beauty of a flow track.
And you don't even have to have it like on the patient. You can have it on the
Yeah, so you keep it, you can put it in here, but again, it has to be at heart
Right.
level. So if you are adjusting your patient in the bed, you just have to adjust this with it. And what do you guys use for your A-line holders now?
a leg strap or
Okay. Would
whatever.
would these be helpful?
Yes.
Anything would be helpful.
So we don't have a lot of transducer holders like in the area. I'm not sure why. We've
Okay.
asked about it, but traditionally transducer holders are the best way to hold them in place, level it, and prevent it from having happies. So we really do want to utilize things like this to clip our A-line monitors on.
Yeah. So yes, and these can this can clip on anything. Clip it on your pole. You can clip it on your bed. Just make sure it's easy, because if you're adjusting your patient's head of bed, this is easy to adjust the transducer with. So we can again, just like that. You can go in, just put it just like that, and then you can just clip it to anywhere. So that, maybe we can get you guys some of
You can
these.
clip those to like an IV pole and stuff.
Yeah. So if your IV pole will be, probably be closer to the patient. We really try to refrain from putting any fluid on this, because we don't want to get any fluid in the components here. But it would just kind of sit looking like this. And this is how it's kind of set up, where this will be going to your bag. So the E for Edwards will always be like that. So, and this will be going to the patient, instead of, I know a lot of
The other way
people
around.
do
That's
this. Do you know what I'm
backwards.
saying?
Yeah.
And the point of this is to prevent bubbles from accumulating. What the technology is set up, right, bubbles will be less if it's set up upright like this. If that makes sense. Okay. Questions on that? Good. And then, since it's a new technology, just like anything, you guys have to play with it, have it a few times for your patients. On here, really, if you want to change something, we have it really set up. You have your blood pressure, your cardiac index, your stroke volume, and SVR. If you want to change any of the parameters, see how you're in the square? So you press outside of the circle, but in the square, it gives us a list of all the parameters that you want. So maybe, you want to look at cardiac output instead of cardiac index, just press inside the square. I get my cardiac output right here. All I do is select that, and it's right here. Inside the circle will be your range. So depending on what your patient's parameters are, sometimes to prevent alarm fatigue, if your patient just has a consistent low cardiac output, maybe there's an older patient with some type of heart failure, and in order for the alarms to stop, you can kind of adjust the ranges, but you might need a doctor's note to do that. There is a silence button down here. Silences it for 2 minutes. The other helpful icons we kind of talked about, you can go to your nursing bag and you have your zero and waveform here. So I'm assuming you zero your lines maybe once or twice a shift, right? There's also a shortcut here, down here, that zero waveform. You can just press it and it's right back. The other icon we talked about was this was the settings. So you just go to settings, patient data. You can change that, but if you have a new patient, you always want to select new patient. Yes.
So when we're zeroing the A-line from there,
Yes.
we have to do it on the monitor.
Yes. Yep. Exactly. So when you're open to atmospheric pressure, you zero here, zero your bedside. The order really doesn't matter. If you want to zero your bedside, come back and then zero here. That's fine. Yep. Just how you normally would do it.
Would you mind showing them how to manually enter a CVP to get the SVR, because we don't have that?
Yes. Good. So if you want to enter, we do need a CVP for SVR, and that equation, it's MAP minus CVP divided by cardiac output. So the CVP in that equation is really not a big, driving factor in the SVR equation. It's really your MAP and cardiac output. But if you go to your medicine bag, a nursing bag, and you have enter CVP right here. So I can enter CVP, hit the millimeters of mercury. So if you are measuring a CVP, you can put that in, or you can just put in 5. A lot of places they'll say 8 is great. Put in 8, and then it'll start to calculate your SVR. But like I said, it doesn't matter if you put in a 1 or a 10. It's only going to change your SVR by about 100 points. And if it's 2,000, your SVR is 2,000 or 2,100. Clinically, we wouldn't do anything different, right? We want to see the trend. So if our trend, we start at 2,000, it drops to 500. Okay, now it's like, okay, the patient's vasodilated, we need to intervene. Does that make sense?
So when we're doing the CVP, entering it, is this just like every hour or every 2 hours?
Nope, you
we
can
copy it?
you can just enter it once.
Once.
But if you are measuring it and you want to update it, I think some institutions they'll do it every 4 hours.
Every 4.
Yeah. But yeah.
You guys understand why that's such a small part, right? It really doesn't matter if you put in 1 or 30. It's not gonna change your number, but that's what the call edge said. Right?
So usually
Was
the
about.
doctor would just ask for it, or it's just like a preference?
Yeah. What do you mean?
You're
preference?
entering the CVP on it.
Yeah. Well, you just
It's
need.
just a preference?
Yeah. Well, not a preference. You just want it to get the SVR.
You won't get a continuous reading of SVR until you go in and put that CVP in.
Oh.
That's why. Yep. What was that supposed to show?
So say you put in 5 and your SVR would be 1,200. You put in 15, your SVR would be 1,150. And it's not differing by very much. And it's certainly not changing how you treat your patient, but you're still going to see the trend of if you clamp down or if you dilate out.
Right. So here, on the screen, we have a derived value calculator. So I put in our cardiac output of 5, I put our MAP of 65, and I put in CVP of 5. That's giving us an SVR of 960, right? So if I change that CVP to say a 10, it went from 960 to 880. So, right, that's 80 points. Right, we're not going to do anything clinically different at that point. Do you understand what I'm saying? Yeah.
Because I probably just gonna comparing it to the LIDCO before. I think the numbers that we copy every hour would have the SVR all the time and then the CVP all the time. I can't remember, but in this one we have to enter CVP to have the SVR.
Yes. Yep.
Previously with the LIDCO, everything is there, SVR is there. So that kind of confused me about entering a CVP.
Yeah, maybe they must give you just an arbitrary CVP value all the time to get SVR. Yep. So yeah, you guys can play with this. You can push buttons, all that stuff. You're not doing anything to the patient,
So
right?
if we are copying numbers every hour, where are the numbers there that we could go back to?
So
and look
there's
at?
I'll show you a thing. So see this other icon here with these little picture screens? If you press that, it's going to give you a bunch of different options to view the parameters. So you can have 1 parameter all the way to 4. And if you want, say you want to go back in history and look at every hour, this top middle one, this graphical tabular screen, this will give you the parameters every hour. And if you want to change it, just hit the time in the box, and you can adjust it to be. We can do it every minute. We can do it every 60 minutes. It's up to you. But that is a nice way to go back in and look at it.
Is it going to transfer over to Epic or?
So it has a capability of transferring over at Epic. Do the other units the hemispheres transfer over?
Yes, and we're working on getting the EV1000s to transfer over automatically, so you don't have to worry about copying numbers.
Yeah, so there's just an Ethernet cable that will get plugged into your middleware here, and that should come over to Epic.
Now, when we used to have the LIDCO, a patient has his own card. Does it utilize one?
You don't need cards.
Nope,
no.
that's the beauty of this. It's non-calibrated and you don't need the cards.
So how is the data saved? Unless we just have to copy it
The data saved in
every
here.
hour there?
In here. So it actually has a USB in here where it can save the patient's data for up to 96 hours, I believe. But you wouldn't,
So
wouldn't
if
do
we
that.
have that in place, are they gonna provide us a, part in the, monitoring Epic, you know, that we, just like the CRRT, you copy it, you enter it
Yep.
every hour?
Yes.
It's
You
already
don't
in
have-
Epic,
It's
yeah.
there?
Yeah,
Okay.
so you
Because
guys-
this is getting used in other ICUs, it's already
Okay.
built in there.
So it will be.
Right, you guys
Okay.
can drop down, add hemodynamic parameters, and then when you right click, everything should pre-populate all for that time that you're
So
entering.
what is it, the bundle, like a, what do you call that name? The
Yeah,
EV1000?
EV1000. I think it's under
The bundle that we
Hemisphere.
have to
It's advanced
open.
hemodynamics
Yeah.
underneath
Advanced
the flow
hemodynamics.
sheet for
Yeah.
vital signs, advanced, and then you have other options with cardiac output, SVR, EVR, all that stuff.
And how did they want us to require the entry every hour?
I would follow your orders, but it is helpful to have these values every
Every
hour,
hour.
and obviously, like they said, it updates every 20 seconds,
Because
so.
before, we didn't have an order, as long as the LIDCO is automatic, every hour you enter it, so.
That's what Pam is doing, the policy as, is
Okay.
every hour, enter the numbers.
Yeah, I mean, just for me, for nursing, I always want to protect, right, myself and document. If I'm doing, say, you know, my doctor just added, like, start dobutamine on this patient. Well, I want to start the dobutamine, but I also want to add my hemodynamic parameters 5, 10,
Yeah.
15 minutes after to show, okay, added what the doctor ordered. This is how our hemodynamics are responding. Again, we always want to protect ourselves, right?
Yeah.
So I would want to put those parameters in
Yeah,
document.
so when you
Yeah.
say protecting yourselves, you know, it's like every person is different, so it will be very helpful if the, policy will be there and
Yeah,
automatic.
you got it.
Because everybody wants to protect themselves, but if you think, to me, it's every 30 minutes, to one is every 1 hour, but you have at least a baseline for the unit that, you
Yeah.
know, you could always make it more often, but the
Right.
minimum is every hour.
Yep.
Correct.
Yep.
Yeah,
And that is what the policy is going to say.
Yeah.
awesome.
Yeah. Questions? Concerns?
Last thing, my number's on there, we'll put Brian's number on there. Seriously, you guys call, text, FaceTime us. If it's at night, call me, not Brian.
I might be up.
I'm available 24/7. If you guys have questions, if you have troubleshooting, FaceTime me, we'll get it worked out quickly.
Is that thing expensive that it needs to be charged?
What?
Yeah,
This?
if they order it,
Oh,
the flow chart.
thing.
Like
The
charging.
charging,
Oh,
yeah,
this?
yeah,
You, I don't know.
the whole thing, if the doctor ordered it and we have to set it up, is it needs to be a charge item?
As of
because it's
now,
very
no.
sensitive? Okay,
I guess the materials management folks are working on building it into Epic to charge for it, but up until now, and it's been used at the hospital for a long time.
Usually with the ICU, it doesn't matter if it's not too expensive, but if it is very expensive, we have to tell the charge nurse that, oh, you need to charge, we use one.
Yeah, right now, you do not need to charge for it.
Alright, thank you.
Yeah.
Thanks, guys.
Cool.
Yes.
Thank you.
Seriously, call us, like, we're here to help.
Yeah, we will. Put the number there.